Clostridioides difficile, also known as C. diff, is unfortunately a pretty common hospital infection. Where I work, I know it's pretty rare that we don't have at least one C. diff positive or C. diff rule out patient on the floor. It was recently reclassified in 2016 from the genus Clostridium to Clostridioides. It was supposed to be Peptoclostridioides, but C. diff is such a firmly established term in the medical field. I think they wanted to keep the genus starting with a C so as not to interfere with any terminology. C. diff belongs to the family Peptostreptococcaceae. I don't know if I said that right. This family of bacteria is often found in ruminants and also in the human GI tract. It is gram-positive, rod-shaped, and obligate anaerobe, and it also has flagella to get through liquid and semi-solid material, and pili to help move across solid surfaces. C. diff is spore-forming, and its spores are probably the reason why C. diff is such a problem. They can reside on surfaces for a very, 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 very long time. I think I read about 3 months, and they are highly resistant to many environmental factors such as heat, acid, oxygen, and common disinfectants. When pathogens enter the body, they're often killed by stomach acid, but the spores are resistant to damage from acid, so it goes right through the GI tract and has access to the colon. Not all C. diff is cytotoxic, but the ones that are produce toxins A and B. These work together. I read that toxin B is only effective with toxin A. Toxin A essentially destroys the structure of a cell, and then toxin B damages the intercellular junctions, so it basically rips cells apart where they adhere to one another. And then there is a hypervirulent strain called NAP1 or ribotype 027. This produces a CDT toxin, which was identified pretty recently in 2005. I don't know if they know exactly how it works, but from what I read, it sounds like it enhances toxins A and B, or at least that's our current understanding of it. And then some people include the polysaccharide capsule as a virulence factor just because it makes it very difficult for immune cells to destroy. It is possible, but not highly likely, that C. diff already exists in your gut as a part of the natural environment. So it's not really until C. diff overcolonizes the colon that it becomes pathogenic. This typically occurs when you're taking antibiotics and you get some disturbance in the gut flora. It creates more space for a bacteria like C. diff to establish itself, and then there's less competition, so it allows it to flourish. So for example, in a hospital setting, say you're taking antibiotics and you have that gut disturbance and you happen to ingest a C. diff spore, that spore will travel down into your stomach. It survives the acid and enters the small intestine. The small intestine is nutrient rich, there's low oxygen, it's dark, it's warm. It kind of lets the spore know it's okay to germinate. So the spore germinates, it turns into a vegetative cell, and by that time it's reached the colon, where it targets the epithelial lining. If that particular strain of C. diff is cytotoxic, those toxins will destroy that lining, basically ripping all the cells apart, causing fluid to leak, and then you have more accumulation of fluid from the inflammatory and immune responses, and there's like fluid, debris, and then not to mention the colon's responsible for absorbing water, so you have already liquid stool. All that fluid accumulates and it comes out as diarrhea. There's no standard incubation period, but I read a report that said C. diff can colonize anywhere from 1 day to 6 weeks or more. One of the main symptoms of C. diff is frequent loose BMs. Maybe this is TMI, but there's a pretty distinct smell and texture. So a lot of the times you can tell someone has C. diff before you get any testing done, but of course you want to get that confirmed by the lab. Other symptoms include stomach discomfort, nausea, loss of appetite, and dehydration from fluid loss. Severe C. diff can cause pseudomembranous colitis, which is basically plaque formation along the colon lining, and these plaques are layers of inflammatory cells, debris, pus, all that stuff. You can kind of see it in the purple histology photo. Toxic megacolon is also a problem where you have a distended colon. That's seen in the image with the x-ray. That can put you at risk for tears or perforation, and you don't want bowel leaking into any other parts of the body, so that can put you at risk for all sorts of infection, including sepsis. Two of the biggest risk factors for C. diff are having a recent stay in a hospital or nursing facility and also taking antibiotics. Again, antibiotics can disturb your natural gut flora and make it easier for C. diff to colonize, and it's not helpful when you're in the hospital full of C. diff spores taking antibiotics. That can put you at major risk. Also, being over the age of 65 and having a weakened immune system can put you at risk, and unfortunately, having a previous C. diff infection gives you a 5 to 20% chance of a recurrent infection. Epidemiological data regarding C. diff is pretty limited for a couple of reasons. One of the reasons is because C. diff is a relatively new infection. It wasn't until 1978 that C. diff was first linked to pseudomembranous colitis. Before then, they were calling it clindamycin colitis because they recognized that clindamycin was somehow linked to colitis, but they weren't sure how or why. They did suspect Staph aureus, and in the 2000s, there was a rapid rise of C. diff infections and mortality rates, so this sort of pushed people to begin to survey C. diff, and it also pushed people to develop new and more sensitive testing. And of course, science is more directed toward Western nations, so that also plays a factor. And also, the hypervirulent strain is, it originated in the US, so that's kind of where all the data is concentrated. I did find a study from the Saudi Medical Journal that mapped out occurrences of ribotype 027, or that hypervirulent strain. It seems that in Chile there's a pretty significant issue, and it has been reported in other countries such as China, Japan, Saudi Arabia, and Australia. I did read sort of across the board that C. diff cases are increasing globally. There are tons of different strains, so this is just one strain that's being mapped out here. C. diff can be found anywhere and everywhere. It is pretty common in soil and in ruminants of animals, and now, unfortunately, healthcare facilities. I did find a study that showed that people who lived closer to livestock farms were more likely to carry C. diff, and I say carry, not be infected by. So you can still have C. diff in your gut flora and not have an infection. Transmission occurs through the fecal-oral route, not necessarily directly, but feces can contaminate a surface, and that surface can contaminate another surface, and that can eventually make its way into the oral cavity. Unfortunately, this is very easy in hospitals where there are lots of spores around a lot of patients who are already immunocompromised or undergoing antibiotic treatment. That's why it's very important to wash your hands. Again, hand sanitizer does not kill C. diff spores. Isolation precautions are also important, so gowning and gloving before entering a C. diff room. Bleach wipes kill spores, so any equipment that's taken out of the room should be wiped with bleach, and also surfaces within the room should be wiped with bleach periodically. And then when a patient is discharged, a UVC light is really helpful to kill off spores. Usually sits in there for like 20 or 30 minutes after a patient is discharged and the room is initially cleaned. And it's also important to limit antibiotic use, so don't take antibiotics that you don't need. It's recommended to discontinue unnecessary antibiotics when diagnosed with C. diff, although this can cause issues, especially if you came to the hospital for something entirely different and you need to be treated for that problem and happen to acquire C. diff in the process. That might interfere with treatment. Ironically, in order to treat C. diff, you've got to take more antibiotics. These should be oral because you want it concentrated in the GI tract. Papers were kind of mixed about which medications work better than others, but it seems like the gold standard currently is fidaxomicin and vancomycin. Both of these treat gram-positive bacteria. They're both highly selective, so they're not broad-spectrum antibiotics, so they're not going to kill everything off. And they're also poorly absorbed in the intestines, so they will concentrate in the colon, where the C. diff infection is. So essentially, they're gentle on the gut. Metronidazole, I don't know if I said that right, but that one's less common. It's a little bit more old school. People are questioning its efficacy, and they're not really sure if they're effective against all strains of C. diff. Another option is a fecal transplant, which I think people are really grossed out by because it does sound kind of nasty. You're taking the feces from a donor who has an established healthy gut flora and introducing it into your own body. So it is a little bit weird, but it does have an 80 to 90% success rate when treating recurrent infections, and that might be worth it if depending on who you are. There's no way to gain immunity from C. diff. In fact, if you are infected, you increase your chances of a recurring infection. And then, of course, we have the hypervirulent strain that may not be treatable because it is antibiotic resistant in some cases. When testing for C. diff, it's important to remember that not all strains of C. diff are cytotoxic and not all carriers are infected. So in theory, you could pull someone off the street and test them for C. diff and they could come out with a positive result. That doesn't necessarily mean they have an infection, but it could just be they happen to be one of the few people that carries C. diff as a part of their normal gut flora. So with that in mind, it's important to test for C. diff only if you have a reason to. So in hospitals, 3 loose stools within the span of 24 hours usually prompts a C. diff test. When testing for C. diff, it's important to test for both the presence of the C. diff antigen and the C. diff toxin. Just testing for the antigen can lead to a false positive because, again, maybe this person just happens to carry C. diff in their normal gut flora. But coupling that test with the presence of toxins confirms an infection. This can be done through a little kit they have. It's the bottom right corner. I think that's a pretty common kit in labs. And then this can also be done through PCR. Stool cultures are not as common. They're very expensive. Results are slow to come back, and it is labor intensive. So you can isolate C. diff from a stool culture and then take that isolate and test for toxins. This is less common. I think it's not really used for clinical diagnosis. I think it's more used for like further studies. So if you are studying the epidemiology of C. diff and need to know a specific strain, you would do something like this. Imaging is not used to diagnose C. diff, but you can diagnose colitis. So a colonoscopy can reveal the presence of plaques. And then an x-ray can also reveal the presence of toxic megacolon or any kind of distension of the bowel. Again, you want to keep an eye on that stuff because if you let it go too far, it can cause a lot of issues.